Hello and welcome to your Neurologic Concerns audio lecture. Welcome to your Neuromuscular Disorder PowerPoint lecture. Parkinson's disease is a progressive neurodegenerative disease of the central nervous system. Its manifest primarily is in motor dysfunction, such as tremors. Factors that are considered to be potential causative factors are as follows: idiopathic in origin, brain injury or tumors, environmental toxins, antipsychotic medication use, and genetic predisposition. Parkinson's disease occurs almost 2 times more in men than in women. Remember, it is a movement disorder. So on this slide here, you can see the pathophysiology of Parkinson's disease. So you can see here that it affects the acetylcholine and dopamine receptors. Clinical manifestations of Parkinson's disease are listed here on this slide. Parkinson's progresses through several stages. Initially, your patient may present with unexplained unilateral weakness and upper extremity tremors. And he or she evolves through this disease state. More pronounced physical disabilities are noted, such as, and you can see here on the slide, a slow shuffling gait, a widening gait, and postural instability. In the final stage of Parkinson's disease, the patient will be much slower, and the rigidity will become more pronounced. Tremors may disappear with purposeful movements. But remember, tremors is an initial sign of Parkinson's. You'll see these types of patients will have tremors at rest. That's very common. You'll see them having the pill rolling, which are tremors of their fingers and hands. These patients are at risk for falls. The diagnosis of Parkinson's disease is made when 2 or more cardinal symptoms with asymmetrical presentation are observed in the absence of other causes. So a progressive decline in motor function accompanied by the tremors and rigidity is typically how the diagnosis is made. Pharmacological therapy is initiated when symptoms become difficult or disabling for the patient. So number 1 is this. Levodopa crosses the blood-brain barrier and is rapidly taken up by dopaminergic neurons and converted to dopamine. 2 is anticholinergics. They can reduce tremors and drooling in younger patients. They also help to equalize cholinergic and dopaminergic activity. Older adults generally do not do as well on these medications because of the side effects, such as confusion, memory impairment, blurred vision, dry mouth, constipation, and urinary retention. Their first line of treatment will likely begin with dopamine receptor agonists, such as Mirapax and Requip. These medications also have significant side effects, such as nausea and vomiting, urinary frequency, drowsiness, orthostatic hypotension, lower extremity edema. So as Parkinson's disease progresses, levodopa becomes less effective. Deep brain stimulation involves a surgery during which an electrode is placed into the thalamic area of the brain using MRI and recordings of brain cell activity during the procedure. A second procedure is performed to implant an impulse generator, which is kind of like similar to a pacemaker and is located under the collarbone collarbone, or in the abdomen. This generator provides electrical impulse to a part of the brain involved in motor function. So deep brain stimulation, or DBS, has a risk of infection, stroke, bleeding, or seizures, and can reduce clarity of speech. Listed on this slide are a number of nursing diagnoses that will guide your assessments and plan of care. To address a few is this: it is important that you protect your patient. So with that being said, is you want to make sure that they have clear pathways, that you've set the bed alarms, and offer assistance. Physical mobility is likely decreased, so their ability to complete their ADLs will decline. But remember, we always want to promote independence. Collaboration with other team members, such as physical therapy, occupational therapy, and speech therapy, are very important. We want to collaborate with those team members to maintain joint flexibility, especially in patients with degeneration of the dopamine-producing neurons. Nutrition-wise, nutrition and aspiration concerns should guide your assessment of cardiovascular function, respiratory system integrity, electrolyte management, and integumentary status. You need to consider patient positioning during meals because they are at risk for difficulty swallowing. So they need to be sitting in an upright position. Suctioning equipment should be at the bedside and in working order. You may need to develop, along with your patient, methods to clearly create communication pathways. Bowel protocols may be necessary to implement as a result of the medication side effects. So we already talked about, or I mentioned constipation, basically because their intestines have slowed down. Psychosocial considerations are related to social isolation and depression, requiring that you facilitate interdisciplinary collaboration within the healthcare team. Next, we're going to talk about multiple sclerosis, or MS. MS is a chronic neurological disorder in which the nerves of the CNS, which includes the brain and spinal cord, degenerate. There is a buildup of scar tissue, which is sclerosis, or plaques that form during demyelination, which is destruction of the myelin sheath. As an autoimmune disease, the immune system mistakenly identifies normal body substances and tissues as foreign and attacks them. There are 4 classifications of MS. Number 1 is this: relapsing, remitting. That's the most common form. So with this classification, it's basically exacerbation that occurs during which new symptoms appear and old ones worsen. The relapse can last for days to months. These periods are followed by periods of remission, where there appears to be partial or recovery. The next classification is secondary progressive. This patient initially had relapsing and remitting of the disease and now has gradually deteriorated. With this classification, the patient may still experience relapses, but these will progress into a general decline. There's no period of real recovery occurs. The third classification is progressive relapsing. Symptoms increase and relapses may or may not have recovery. And the last classification is primary progressive. In this form, there is a gradual progression, no remissions, and maybe only temporary plateaus. The initial disease activity is in the spinal cord, not the brain, so these patients are less likely to develop cognitive problems. The pathophysiology of MS is this: Myelin is the protective sheet that surrounds the spinal cord and nerves. It protects and facilitates impulse transmission. The blood-brain barrier that separates circulating blood from the brain's extracellular fluid is present to restrict the passage of solutes from the bloodstream. As the blood-brain barrier breaks down, immune cells infiltrate and attack the myelin. Clinical manifestations associated with MS is this. Your patient with MS will likely demonstrate a number of different manifestations. You may note mental changes, decreased concentration, attention deficits, or memory loss. He or she may appear depressed or in an unstable mood. The patient may complain of visual disturbances, blurred vision, color distortions, vision loss, or eye pain. Limb weakness. An early characteristic of MS is limb weakness, especially in the legs. They also could have a loss of coordination and balance. So again, these patients need to be placed on a fall risk. There may be accounts of muscle spasms, fatigue, numbness, tingling and prickling pain in the extremities, loss of sensation, speech impediment, tremors, or dizziness may be present. Bladder and bowel dysfunction may also occur. Because symptoms of MS may be irregular or mimic other diseases, it is difficult to diagnose. Additionally, there is not a specific test for MS. The neurologist will do various things, such as an MRI. So, again, you would educate your patient if they were going down for an MRI, it's going to be loud and not to move their head. The neurologist may do a lumbar puncture to evaluate CSF. They're looking for high amounts of protein. Medication-wise, has its focus on several areas. Medications are prescribed to modify the course of the disease. Strategies that are used to treat attacks include corticosteroids. And as nurses, we would also be monitoring glucose levels. If you recall, steroids interfere with glucose metabolism by blocking action of insulin. So just remember that. Other strategies are plasma exchange or plasmapheresis to decrease the inflammatory and immunologic factors involved in the exacerbation. Also, a third category are those medications used to treat clinical manifestations, such as muscle relaxants and meds to decrease spasticity. Physical therapy is helpful for muscle strengthening and to improve daily function. Again, it's also to help prevent falls. Finally, medication may also be prescribed to help reduce fatigue, depression, pain, and bladder or bowel problems. With regards to the clinical manifestations listed here, your areas of assessment may include the following. Neuromuscular function. So you would be evaluating for changes in clinical presentation or for new symptoms to be addressed as the disease progresses and new areas of demyelination occur. Also, you'd be looking at vision and eye movement. Demyelination of cranial nerves can result in optic neuritis, which can cause visual changes. As a nurse, I'd also be assessing their skin integrity. Immobility promotes breakdown as a result of compression of soft tissue between a bony prominence and an external surface. Also, this compromises blood flow and decreases delivery of oxygen and nutrients to cells, resulting in cellular death and injury to the surrounding tissue. As a nurse, I'm also evaluating the ability to perform their ADLs. Evaluate the need for assisted devices to decrease the danger of falls. Also, assessing bowel and bladder function. Let's see, impairment to the bladder and bowel may result in incontinence and constipation. So as a nurse, I would develop bowel training regimen and encourage fluid intake with these patients. Remember, as nurses, we're educators, so teaching would include the following: the need to take prescribed medication to decrease exacerbation, to slow disease progression, and to treat symptoms. Also, in order to receive the earliest treatment possible, your patient must be aware of the early signs of exacerbations. It may be helpful to review the disease process to increase your patient's understanding and enhance their ability to make informed choices. Myasthenia gravis. In the development of normal nerve transmission, ACH is produced and secreted at the ends of motor nerves. It crosses synaptic clefts and attaches to ACH receptors lying in the folds of the postsynaptic membranes. This binding process results muscle membrane depolarization, causing skeletal muscle contraction. In myasthenia gravis, or NMG, anti-ACH receptor antibodies bind with ACH receptors, causing destruction of receptor sites. The postsynaptic membranes lose their folds and ACH binding is blocked. In myasthenia gravis, remember that there is adequate amount of ACH released, but postsynaptic receptor sites are not available. The result is skeletal muscle weakness and fatigue. It is an autoimmune condition where the body attacks muscle receptors that control voluntary muscles, which leads to muscle weakness, and voluntary muscles are involved. And it's mainly the eyes. The majority of people affected with myasthenia gravis have identified acetylcholine receptors, and the remaining 20% fall into the other two categories listed here. Patients test positive for antibodies against muscle-specific tyrosine kinase MuSK, which is a protein. Myasthenia gravis do not have acetylcholine receptor antibodies, so they're seronegative. 70% of patients with MG, or myasthenia gravis, have thymic hyperplasia, which is an enlarged thymus, which is located in the chest behind the breastbone. Remember, the thymus gland is an organ of the immune system that produces T cells or T lymphocytes. Only about 10% have a tumor of the thymus gland, which is a thymoma. The tumor is normally benign and enclosed. Patients with thymoma typically have higher levels of antibodies and subsequently experience a more severe disease course. MG is categorized into ocular, bulbar, or generalized presentations. Patients will often pursue medical care for muscular weakness and fatigue. 2/3 of patients with MG present with ocular symptoms, specifically ptosis, which is drooping of the eyelids, and diplopia, which is double vision. Again, it affects the eyes most. The ptosis may be unilateral or bilateral. Diplopia is a result of extraocular muscle weakness. Ocular symptoms may worsen with activities that require sustained use of the eye muscles. Bulbar indicators include symptomology related to cranial nerve 9, 10, which is the vagus nerve, 11, which is the accessory nerve, and 12, which is the hypoglossal nerve. These nerves emerge from the medulla of the brainstem. Symptoms include difficulty with phonation, chewing, and swallowing, so their throat muscles become really weak. General presentations include trunk and limb weakness. Proximal muscle weakness is experienced more than distal muscle weakness. Weakness can vary throughout the day, but typically it worsens later in the day, and symptoms worsen with sustained muscle use. Patients often complain of difficulty with completing activities of daily living. So on this slide here are the nerves that are involved in myasthenia gravis. A little bit about each of the sections listed on this slide are as follows. Serological testing specifically targets AChR binding antibodies. This test is very specific, and positive antibody studies verify MG. Electromyography evaluates neuromuscular transmission and measures muscle action potential. The Tensilin test uses a short-acting anticholinesterase medication administered IV. Observations are made related to changes that occur with ptosis. The risk with this medication is that it can have significant side effects, including the following: bronchospasms, bradycardia, and diarrhea. The reversal agent is atropine and should always be available during this test. Again, that's the Tensilin test. The CT scan is used to evaluate the patient with MG for thymoma. Remember, that's the tumor, and it originates from the epithelial cells of the thymus. Medications such as pyridostigmine improves neuromuscular transmission. Neostigmine IV version of above, IV routes are necessary. So as their nurse, you're going to monitor their IV site on a regular basis. The principal immunosuppressant medication is prednisone. Cautionary medications are labeled such because they can have an adverse effect on neuromuscular transmission and may lead to increased weakness. Remember that antacids and laxatives contain magnesium, and magnesium can inhibit release of ACH. IV immunoglobulin, which is autoantibodies in the blood that target acetylcholine receptors, are the key problem in myasthenia gravis. IVIG consists of immune globulins collected from donors and acts to destroy and neutralize these autoantibodies in the bloodstream and to block the production of new antibodies. And this medication must be administered slowly, and as nurses, we are assessing their vital signs frequently. In plasmapheresis, the patient's blood is removed through an arterial lumen and circulated through plasmapheresis machine, which removes antibodies that block AChR function. Myasthenic crisis is an exacerbation of MG weakness, often causing respiratory issues. It is frequently the result of a respiratory infection. The weakness may involve the respiratory muscles, and it may affect the patient's ability to protect his or her airway. Additional symptoms are a rapid heartbeat, muscle changes, and skin that appears pale and is cool to the touch. A myasthenic crisis is an emergency situation that requires prompt recognition and ICU treatment. Another type of crisis that the MG patient may encounter is a cholinergic crisis. This is simply due to excessive anticholinesterase medication and is potentially secondary to the patient taking too much prescribed MG medication. It may be difficult to distinguish with crisis whether it's cholinergic or myasthenic. The patient is experiencing due to similar features. In this situation, the Tensilin test, which is used to diagnose MG, is used. Also, the enzyme acetylcholinesterase breaks down acetylcholine after the muscle is stimulated, preventing prolonged muscle response to a single nerve impulse. So these are administered. If the patient demonstrates muscle strength improvement, it is a myasthenic crisis. If the patient demonstrates fasciculations and muscle weakness, including respiratory muscle, it is a cholinergic crisis. Just remember with these types of patients, you always want to put them up into semi or high Fowler's position. We're protecting airway and we don't want them to choke. ALS is a disease of unknown origin. It results in progressive muscle weakness and progressive wasting and paralysis of the muscle, but does not lose cognitive function. As a progressive neurodegenerative disease, it affects nerve cells in the brain and the spinal cord. When a muscle has no nourishment, it atrophies or wastes away. Lateral identifies the areas in a person's spinal cord where portions of the nerve cells that signal and control the muscles are located. As this area degenerates, it leads to scarring or hardening. The cause of ALS remains unknown. A number of causes and risk factors have been proposed, but none are positively proven to exist. In the pathophysiological process of ALS, a degeneration of upper and lower motor neurons occurs. As this progresses, voluntary muscle actions and functional capacity declines. Clinical manifestations will be evidence as you assess your patients. Your patient may demonstrate any or all of the following: variable hyperreflexia, which is overactive or over-responsive reflexes; clonus, which is a spasmodic contraction and partial relaxation of a muscle. They may also demonstrate spasticity. You may also see an extensor plantar response or the Babinski. And limb or tongue fasciculation. Fasciculation is an involuntary contraction or twitching of a muscle. It may be noted in the tongue or a limb. As the disease process progresses, the ability to swallow, speak, and breathe becomes impaired. They are at risk for aspiration. Medical management. So no cure exists. Riluzole is believed the drug that blocks the release of glutamate from nerve cells. It is believed that excess levels of the neurotransmitter glutamate damages nerve cells. Most patients with ALS are managed at home and in the community with hospitalization for acute problems that arise. The most common reasons for hospitalization are dehydration, malnutrition, pneumonia, and respiratory failure. Recognizing these problems at an early stage in the illness allows for the development of preventative strategies. As functional impairment increases, greater depressive symptoms may manifest. Once your patient begins to experience aspiration and swallowing difficulties, Internal feedings must be considered. Decisions about life support measures are made by the patient and family and should be based on a thorough understanding of the disease, the prognosis, and the implications of initiating such therapy. Advanced directives should be discussed, as well as end-of-life issues, including pain, dyspnea, and delirium. Nursing management for these types of patients. Respiratory maintenance might include the following: upright positioning, upper airway suctioning, and encouraging the use of the incentive spirometer. You will conduct ongoing assessments for signs of hypoxia, such as tachypnea, restlessness, poor sleep, excessive fatigue. In order to maximize your patient's mobility, encouragement of usual activities that do not result in fatigue is necessary. Physical therapy is used to strengthen unaffected muscles, along with range of motion to prevent contractures. Also consider the introduction of assisted devices to help maintain independence. Remember, we always want to promote independence for our patients. Their diets, it must be high in calorie and served in small, frequent feedings. But certainly allow your patient to be part of the food selections. Consider food textures to minimize aspiration risk. Additionally, with respect to aspiration, upright positioning, instructing the patient not to talk while eating, and showing them how to hold their breath while swallowing will be beneficial. Fatigue, it's a constant risk for these patients. Encourage the patient to accomplish most important activities early in the day and to take frequent naps. It may be necessary to acquire mechanical speech aids or a communication board to enhance social interaction. So as the nurse, in order to minimize the risk of aspiration and infections, you will want to monitor swallowing techniques. Discourage excessive bed rest, because as nurses, we want to prevent pulmonary stasis, and you're going to consistently want to monitor their vital signs. Also, you may need to teach caregivers at home how to perform suctioning and administer gastrostomy feedings. Additional assessments may include home cleanliness and importance of influenza and pneumonia vaccines.